So, good evening, namaste, and sasrikal, vanakkam. Welcome to yet another episode of SAFE from Patient Safety Fellows of Association of Nurse Executives India. Happy to see many of you here before time. So, let me just do a little bit of introductions before I hand over to the session today. So, SAFE stands for Safety Awareness for Excellence, and this is being hosted by Annie Patient Safety Fellows. Annie Patient Safety Fellowship Program, this is the fourth cohort ago, and this is in association with Patient Safety Movement Foundation USA. They are kind enough to endorse the program, and so far, the approval to hold it in collaboration with them has been continued because we were able to impress on them the hard work put by patient safety fellows, because that is very important for them to continue to endorse us. And I'm grateful to all the patient safety fellows who have job so far. The intent is to influence the culture of safety, and every cohort has been doing learning sessions on different topics all these years. And this year we have a combination of safety topics along with quality improvement projects, which were presented in just about 7 minutes during the annual patient safety conference, which was held in Bangalore last year. So they are going to present their QIPs, and the rest, the Annie Patient Safety Fellows of 2024 to 2026, they will be in sessions. So I am very happy and honored to present Professor Elizabeth Workey, Patient Safety Fellow 23 to 25. She had presented this during the as part of their program, but it was just dealt with in just so that's why they are taking now to explain the project in detail to others. Before I invite her, I have few more slides to cover. So in April, you will see Dr.
I'm you.
I'm you're on mute.
Hey, Bapre, you are too late, huh? My goodness. No one told me I am muted and I had been nicely talking. Okay. Someone muted me or what? I don't know. All right. So I'll start over again. It's okay. It's getting recorded also. I'm sorry that. So I was saying that this safe sessions are brought to you by Annie Patient Safety Fellows. This has been named this year Safety Awareness for Excellence. So monthly learning sessions are presented by Annie Patient Safety Fellows around same time. And this fellowship program is in collaboration with Patient Safety Movement Foundation USA. And they continue to collaborate with us because they are convinced that our fellows do a very good job of learning and then sharing topics around patient safety. And also, all of them do a capstone project as part of the fellowship program. So we are very proud of this program. So this year, the calendar has been already prepared. So that is a combination of quality improvement programs, which have been already presented by Annie Patent Fellows last year. And because they only got 7 minutes to present, so there was some feedback they would love to hear the participants. They said we would love to hear more of those projects. So some of the projects are being showcased this year, and the rest of the sessions are being taken by the safety fellows from last year. This year, we will have a new cohort of patient safety fellows. So today, the presentation of the QIP, Quality Improvement Project on intra-hospital transfer of patients on non-invasive ventilation, is being presented by Professor Elizabeth Workey. She's a fellow from 23 to 25. So 2 years program. And in April, you will see Dr. Geeta Parvanda, and a patient safety fellow 24, 26, speaking about appropriate use of restraints. You find that all the topics that are chosen are very close to the really practicing nurses and extremely good for nursing students and faculties and educators. So now from there, I would like to invite all of you to join us in Kochi on 30th and 31st of May at Grand Hyatt for our flagship program. This is our fifth annual conference, ANICON. So I will show you a very short video to encourage all of you to join us. So thank you everyone and hope to see all of you at Kochi, in Kochi at Grand Hyatt, 30th and 31st of May. The competitions are being invited for research papers, for innovation projects and green projects, and the last date is 31st of March. So thank you all for joining us. Good numbers before we could start. Now, a very, very warm welcome Professor Elizabeth Workey, and over to you for your project. Thank you.
Thank you, ma'am. Is the slide visible, ma'am?
It is.
Yes, just put it on slideshow. Yeah, that's it. Thank you.
Thank you once again for this great opportunity to be with you all today. So this is a project which we have done based upon our safety fellowship program, which has been under the collaboration of Annie. And this was a great journey for us, indeed. So we had done one quality improvement project. So the project which I have selected was the intra-hospital transport of patients on non-invasive ventilators. So I belong to the cohort 3. So this project team was the organization which we have conducted as Baby Mole Hospital, Kozhikode, Kerala, which is a 490-bedded hospital. The champion for this project was Mrs. Gracie Mathai. Project leader was myself, and my mentor was Dr. Rosalyn Rachel. She was a patient safety fellow, cohort 2, and the team members were Ms. Pisa, Tirtha, Lissy, and Amrita. So moving forward, just to give a brief introduction about this background and what was the significance of taking this as a project. So we all know that intra-hospital transfer of all critically ill patients are done for diagnostic as well as therapeutic procedures. So you can see that moving patients from critical areas is all associated with 70% of complications and 2% of mortality. So transportation of such patients need careful preparation, and the time spent outside a controlled environment could be 30 to and what the researchers and the evidence base say. So what we can see that before transferring patient from for these investigations or to some other departments, we normally the hemodynamic stability, the line sensitive medications and occupations. But the important fact, no importance are being given to the equipment which has been assisted with the patient. So this is the area where we had to look into and to come up with a quality improvement project. So this title of this project is Intra-Hospital Transfer of Patients on Non-Invasive Ventilators. So there was 3 incidents where we had some complications while transferring patients on BiPAP. You all know that these types of invasive equipments are creating so much cumbersome, or it is like they're getting many of staff nurses to be confused, and they are not even knowing how to these equipments along with the patients. So in view of the occurrences of these fatal complications while transferring patients on non-invasive ventilators, we as a team decided to take up the quality improvement project to reduce the incidence of any further complications to achieve a benchmark of 0 incidents. With this in aim, we have done various kinds of review of literature. So review of literature says that normally any patients on NIV, probably we transfer them from ED to any investigations, or ED to ICUs, or from ICUs to some other departments also, basically for the radiological investigations and so on. So what happens is like this NIV or the ventilator which is being associated or transferred along with the patient is not being given much importance, thereby creating various kinds of complications, even mortality also. So this review says that the duration of these transports is basically restricted to 10 minutes, 10 to 20 minutes, but based upon the infrastructure that we have, as well as the waiting time for the lift, the escalators, and all these kinds of problems create various loss, or it is a kind of loss for many of the transferring time for the patients. So this again creates complications, and it is going to have certain kinds of central events too. So in order to prevent such kinds of any complications or any sites of increased fatal conditions, the proper preparation of these transfers is important. For that, we need a proper planning. We have to see for the associated or accessories that the patient might be having. Also, we have to prepare the other side where the patient is about to proceed. So they have to be informed properly, and the way has to be clear. So this is basically is being done, or the review of literature says, and evidence-based practices also mentions that a proper planning and preparation is a need of the hour. It's a vitally important part while transferring a patient. So the basis potential complications involved with transferring these patients, especially in non-invasive ventilators, are they might be having any NIV disconnection. The person may go to hypoxemia. The patient might have arrhythmias, aspiration, and even because of these problems, finally we are creating various kinds of second victim. So I would like to share an incident that happened in our hospital too. A patient was shifted from the radiological department to the particular ward. So the patient was on NIV. So basically, the patient, normally we have a backup of this BiPAP, and the patient was shifted. In between, we could see that when the patient was about to enter the lift, the patient developed severe desaturation, and suddenly the patient was shifted immediately into the lift because the nurse was panicked. She didn't know what to do immediately, and the patient was shifted to the room. So there we could find out that the patient's saturation was down, and we identified that the BiPAP was off. So suddenly all the emergency measures was escalated, and the patient was saved at the same time. But here again, what I found out, the tragic thing was that my nurse who was accompanying the patient had become the second victim. So she was feeling like, we all know that the second victim, what we means, the first victim, the patient, of course, the second victim is the person or the nurse or the doctor who were treating the patient. Like they were having the increased anxiety. She was so depressed, and she took around 2 weeks to come up back because she was feeling that, oh ma'am, which was just because of my incompetency, or I was not properly prepared, or I didn't knew how to handle this BiPAP. So this created a great insecurity, or she was feeling so much depressed inside her, and she really was becoming a second victim. So here again, I feel that in our normal setups or in the hospitals where we work, there's a chance for these kinds of complications to happen, or these kinds of adverse events to happen. So I feel that there was a great important need to identify this problem at an earliest and some interventions to come up with. So we have done an RCA with this incident, which I have already described. So we have seen that the staff turnover is a great problem. I think all of you, all the leaders here will agree with me that the staff turnover is a great challenge for all of us because we will not be able to train them accordingly. Even the staff unawareness about the equipment, because we can see that nowadays the BiPAP is of different forms, different companies and different setups they come up. So it is very difficult, it is a challenging aspect for us to teach each and every equipment where even the curriculum does not emphasize on these kinds of equipments in the nursing also. So unawareness about the legal complications. We basically we're unaware, like if something happens, nurses are much like they are not having that much into, or they're not going into the depth of legal implications when it happens to a patient. And no check by seniors was done before the patient was transported, and unreadiness of the team where the patient was about to receive more time to return. As I already mentioned, the architectural planning or the building complexities, all these makes the more time to return. And there was no proper checks for the patient as well as for the equipment, improper communication between the receiving area and the person who was about to transport. and more time outside the controlled environment. And specifically, we have seen that was a low battery backups for the BiPAP, and less awareness about the equipment, as already I mentioned, and improper communication as poor preparation. So this would lead to patient mortality even. So the objectives of this project was to analyze the root cause of patients' lead saturation during BiPAP transport, to develop and implement a standardized process to ensure patient safety during transport. And finally, the objective was to evaluate the effectiveness of the intervention in reducing complications while transferring patients on non-invasive ventilators. With this in view, the story starts here. So at the beginning of the project, as I already mentioned, there we had 3 incidents, but it was really shocking to see it was all related to this during the transport, and basically on the related to this equipment. So we have done a detailed RCA and we had a plan. So we just wanted to concentrate on these objectives that we have come up with. So really we wanted to see any kinds of innovative technologies so that it goes into the nurses mind, and they will capture from that themselves to feel that these may cause legal complications. So I didn't want the next time the second nurse to be a second victim when transporting these kinds of patients, as well as to maintain the safety of the patient also. So we have developed a checklist as well as staff education. So that was a do we have done. So in that we have developed a checklist known as ESCORT checklist, which I'll be explaining in detail. And the innovative methodology that we have come up for this learning process was a mode code and a precautionary tale and data collection, which I'll be explaining to you in detail. And the study analysis was done, and we have done the implementation phase was taken up. So this is a mode code. So this is a kind of simulated forms of code in which we'll be having the judge, the lawyer, the defender, as well as the respondent. And we also have this a kind of code where it's a kind of simulated code where we have all these kinds of defense and the procurements will be done here. So you can see in the picture also there is a judge sitting there. It's created like a court itself. So we have the lawyers, judge, the defender is there, the respondent is there. There's a court clerk sitting here, and the victims or the relatives are here. So this in here in this code, simulated code, the incident is being described, and it has been defended there. So the victim as well as the respondent, what we say, and the judges, they'll be having a conversations about each and every steps. So this makes and this gives an awareness to the nurses, feeling that each step is important. Even if you provide a webinar or if a seminar, normally I know that everybody will just hear and go. But when this comes into their mind, like each and every step before you, it is like they'll be asking, questioning the nurse or the person who has been transporting the patient. So they ask them like whether the step was followed, whether this check has been done. So what would have been a complication? So this goes dramatically into the nurse's mind also, thereby preventing from various errors. And this has been especially given highly good feedbacks by the nurses, even saying that they were really able to understand the depth of or the implications of this legal aspects. Because they used to say that before they go there, learn many kinds of, they have attended various kinds of webinars and seminars, but this is a kind of impact which they had into their mind. Identifying that what is the real thing which has been happening. And finally, we also have a kind of we take some kinds of opinions from the judges also. We had some people here around, so they also will be giving about the verdict, what has to be done based upon the severity of the incident. So this was a kind of innovative teaching technology in order which has been implemented in order to make aware the nurses about the incident. So after that, we had come up with another teaching methodology which was known as a precautionary tale. So this is similar like a skit in which the two parts will be there, or two sessions are being demonstrated, enacted. So the first session will be the normal thing that has been happening everywhere with some kinds of humors and all. You know that what is really happening in our clinical settings, where we have protocols, we have guidelines, but we don't follow all those things. We have our own guidelines and protocols. So that has been demonstrated or has been shown here. And sorry. So second, we have second thing is like the second section will be coming where the actual process, how it has to be gone. So they will be describing about the guidelines on each and every steps, how it has to be followed up. So here we have seen that based upon this precautionary tale, we could see that the various steps, how it has to be taken up while a patient is being transported has been escalated by means of this checklist. So the checklist was developed, it was known as ESCORT. It is a modified intra-hospital transport checklist. So it's a kind of loose, closed loop communication. So closed loop communication means if I check this check, if I do a check, some senior will be repeating back. So this is how it has been maintained. So this ESCORT is a kind of acronym which says that E for equipment, S for systematic, C for communication, O for observation, R for recent investigation, and T for team. So here we could see that in the equipment, various other parameters were also observed. Basically, related to the equipment, whether the patient on ventilator support devices are, if it is needed, and secured patient on trolley, like the side rails and belt was secured. Whether the cardiac monitor was connected with all the leads or pulse oximeter, the emergency drugs, oxygen fluids are being made available, ambu bag is checked, whether the battery status of the ventilator devices and oxygen level in the oxygen cylinder was identified. Even where you have to consider spinal immobilization necessary and secure the Eurobag drains and ICD appropriately. And when it comes to S, the systematic, to identify the patient and confirm the stability to determine suitability for transfer. So confirm airway is secured, patent intravenous access points are being done. So that includes the systematic parameters in the systematic account. Now coming to C, it is communication. So we have to check whether this has been informed, like if not, so written family regarding transfer, or we have to obtain some verbal consent also. Then confirm transfer requirements and expected time of arrival with the receiving unit. So we'll be confirming to the receiving area or the receiving unit that this patient is being about to be transferred. And we are seeing that whether all the requirements have been fulfilled there. If they want any oxygen point or any sets of plug points, where if sometimes the BiPAP has to be charged. So O is for observation, full set of critical observations are recorded. And R is recent investigation. So we'll be giving the handover document if it has been completed or not, recent investigations of any critical values, and also investigations related to the MRI, CT, or the arterial blood gas has to be confirmed. And finally, the team. So T indicates a team. So skill mix of transfer team should be appropriate. So it is not that a single nurse shifts. We should have a team for all these kinds of things to be secured and to be transferred, as well as the medical team also. So protective clothing to cover patient if it is available, and our unit is safe to leave. Like starting point and destination, we have to see whether it is safe to move the patient, and we will be announcing the code according to the patient condition. So you also might be having in various institutions, like we'll be announcing a code for the passage clearance. So similar way, all these things is being planned and executed, and only then the patient will be shifted. So this is a modified checklist which we have implemented now in every area. Wherever the patient with any kinds of non-invasive ventilators are to be shifted, any equipments even, they have to be shifted, or the patient is sick, they have to see to this checklist, and this closed loop communications be done with a team leader accompanying with the assigned staff. So the assigned staff will be the team leader will be verbally asking whether this has been done, or whether the cardiac monitor is connected, like this, the similar checklist which she will be putting up. So the assigned staff has to confirm it back. Yes, the battery is checked, like that. They have to confirm back. So this is how the closed loop communication was come up. So this has been found to be very effective and very simple to use, and especially related to this BiPAP equipments. As you all know that the backup will be normally for every BiPAPs, it is the standard that 4 hours of backups used to be available. But sometimes we can see that we will not be able to make sure whether it is of the full charged, or whether during the transport of the patient, whether there is a possibility of the charge to be drained, or as I mentioned, when we go around more than, if it takes more than hours, like the patient might be waiting somewhere, the patient might go to the X-ray, MRI, they might be waiting there also. So such kinds of areas where there are chances for the leakage of time. So here all we can have this checklist, which is about to be just so safe before transporting any of the patients to any further investigations. So with this implementation, we found out that the pre-intervention, as I already mentioned, there were 2 incidents. One incident 2022 and 2023, we had 2 incidents, and we have provided this intervention in which the staff were made aware about the legal implications by means of mood code, and the precautionary tale was also done. And finally, the implementation of the checklist. With that, we could find out that the post-intervention, there was no single incidence of any sorts of mishaps during transport of patients on NIV. So the moving way forward, we are insisting on regular training for these things. The checklist audits are also on process to see that whether the staff is following the same while transporting any of the patients. So we are planning to expand this implementation to other hospitals also nearby. We have given various kinds of trainings also, like when we handhold them for any of their processes, we are happy to implement those things, like especially in the aspects of mood code and precautionary tale and this checklist. And we have got a very good feedback regarding this also. So this has been helpful for understanding, as well as for helping to share the information before starting a patient. So to summarize, this has addressed the problem of patient desaturation while transporting, and while implementing this ESCORT checklist, we could utilize all the innovative teaching methodologies, has come up with so effective interventions which led to the complete elimination of these incidents. So this is how the study was completed, and presently also we are seeing to the compliance of this the way of transporting patients, and we could see that there was recently also we had done an audit for this, and we could find out that most of the areas, like around 90% of them are doing it. Still, there are lacunae of 10% where there is more intensive training has to be done, because we are getting new staff here, so that is also a challenge. So we are implementing, or we are educating them in our even in our CNEs as well as in the induction training programs also. So this is how the project has been come up, and we could see that it really had changed, or really had made the staff aware about the importance of checking the ventilators or the equipments associated with the patient. Basically, we all know that when we shift, or when we when we just transfer a patient to one department to another, we'll be checking all other areas like the patient hemodynamic stability, the IV fluids, or the patient's condition. But less importance are being given for these kinds of equipments, and we are also unaware about it. So this has come up with a very good feedback also from every staff, as well as the implementation was feasible and found to be practical also. So with this, I think I've done with my presentation. So any questions, anything is welcome to be answered.
Thank you. Thank you, Elizabeth. Very interesting and a novel problem and novel solutions, right? So I will hold on to my comments. Let me open the floor to the audience here. If they have any questions, any doubts, clarifications, or any comments, please go ahead. Nice to see 100+ people in the audience today, though it is a 7 p.m. session. Good. Yeah, go ahead. This is a problem with our people. When we ask for comments and questions, it is like, we are here, we will not talk. Unless we have questions, comments, doubts, there is no further learning. Neither are you reinforcing what you heard. Yes, ladies and gentlemen, waiting.
Good evening, ma'am.
Good evening, Dr. Devinder. Good evening.
This is very nice initiative, nice project you have selected for last year, I must say. Like, this is very good that we have to prepare some checklist, because many times a patient went to some radiological examination, there is a very, like any problem, patient sometimes they suffer during investigation or sometime. I think this will solve the problem in many of the hospitals. But moot court idea is also very new, I think. Okay, how to teach them what are the legal implications, because otherwise we have not experienced. Only moot courts are held by the people who are studying law. So this is a new concept that you have used for the training of nursing personnel. I think this is very good, that initiative you have taken, the moot court. Otherwise, I have heard only the candidates, those like students, they are studying BA, LLB, there has the experience of moot court. Otherwise, nursing I have never heard.
Yeah, come to Kochi. There is moot court during Anicon also.
I will come, ma'am.
Yeah, I'm telling all the
I'm-
people here, you want to see the power of all these things. The principles are simulation.
Yeah.
The
Yes.
principles underlying, whether it is a moot court or a precautionary tale, or you do even a what you call satirical presentation of a problem, all of them actually follow the principles of simulation. And in that also you will find all these phases: pre-briefing, briefing, the simulation itself, and then debriefing. Because if you don't have all these segments in anything that you do, the learning can get limited. But moot court is definitely a fantastic idea. So please come to Kochi to watch.
I will come, ma'am. I am trying to come. I am just get the registration, and I am planning where I'm looking where I have stay. I have to stay this and that. I am just looking other options.
Okay, great.
I went to Chennai few years back, so now I will try to go to Kochi.
Okay, great. So I have a question, Elizabeth, is that
Yes, ma'am.
when you do this moot court once, did you record it?
Yes, ma'am. This has been recorded.
So you can use the same recording to do another set of people?
Yes, ma'am.
So you can continue to use this to train
Yeah.
as many number of nurses as you want. So when a new nurse comes also, you don't necessarily even have to tell them, if you upload it somewhere and give them a link and say, okay, watch this and come, and
Yes, yes,
tomorrow we will have a discussion around that, right? So
yes.
that is called flipping the classroom.
Yeah.
So I am just bringing this out for ideas for all the people sitting here, whether they are faculty, whether they are educators, whether they are nursing heads. Uh, it has to be an engaging way of educating people. And today's generation, they have got very limited patience of learning, sitting and listening to lectures, right?
Yes,
So,
yes.
so I think that's a fantastic idea, and that idea is open to everyone. When you do one-time effort, don't forget to record it. And when you record it, you don't have to repeat. You can, at least for that particular event. Like that, when I was listening to you, I was just thinking, if anybody has, close to, very serious adverse effect, or even a sentinel event, fall is the problem, you know. So all this can get converted into moot court, and then the debriefing can be included there, and then you can multiply your efforts if
Yes,
you
ma'am.
do that, correct?
Yes, yes,
So,
ma'am.
Davinder, that's also an idea for you to teach your students.
Yes,
And
ma'am.
being the classroom has become very, very prominent after COVID for sure. And this is a way that many universities and even schools, they are adopting this, because my niece is there studying in school in Gurgaon, and they keep telling that we are only having discussions in the class.
Yes, yes.
We are asked to go research, find something, next day come and just discuss. But we tend to have lot of presentations. They are sitting through presentations, and there are
Now
no.
they have flipped classroom idea, na ma'am. The flipped classroom is very important nowadays if you have to teach the students.
It has to be engaging, so that's very
Yes,
important,
ma'am.
right? Maybe you would like to explain, Elizabeth, a little bit around the precautionary tale part.
Yes, ma'am.
The word precautionary, can you
Yeah,
explain that
precautionary
once?
tale, actually, the name we had put as because it's a kind of precaution. It's a kind of story to make others understand that's a caution for you. So it is really actually, it's also similarly way that's engaging, where the first part is like what happens really. Because we all know that the hospital setting, the morning, evening, night, we'll be having three hospitals. Morning will be a special hospital which is systematic. Evening will be a little more down. Night will be entirely different. So these three aspects we can see there when the supervisors around and all, it is different. So here you can see that in the evening, night and all, what all things happens. It is really depicted here during the first phase, in the first session. So all these kinds of funny things that we see, so that all things comes inside that. And second is the actual process, what has to be taken down or done. So it's like based upon the protocol and procedures that we have developed. So they have to go through these steps. So that has been explained there, and it has been enacted.
So
So
that was
this,
also recorded. That was also
yes,
recorded.
yes, yes, ma'am. 2, 3 we have recorded, not all. 2, 3 we have recorded because we have here the CNEs. So every department has been given this moot code, assigned time for this. So they will be coming up with any of the incidents which have happened. So any of the incidents, so they can pick up anyone and they come up with this moot code. Second precautionary tale also similar like this precautionary tale. We have given already a list of the procedures which they have to show. So they come up with this funny things. So that's really engaging also.
Very good. I think you should record all of it, because it will become a bank, learning bank.
Yes, ma'am.
Good. You can actually give the links to them to
Yes, yes.
watch and then come and participate in a very engaging discussion,
Yes.
really help. Okay.
Some of things we have recorded already because we have a kind of a blended learning during the induction program. So in that we have a learning platform which we put into small bits. Even now, as ma'am already mentioned, that the generations are all below the behind the reels. So in the form of small reels, also we are making up some things.
Okay. I think technology must be used to to the
Yes,
best,
yes,
result. It is important. If we fail to do that, then we will not get anything different from what we have been getting anyway. Great. Thank you for those answers. Yes.
Elizabeth ma'am,
Ma'am,
can I get
ma'am,
one link so that I can show to my students
Sure, ma'am. Sure.
the moot code recording?
I can share. I can.
Thank you. Thank you, ma'am.
ma'am, I
Ma'am,
want to
from
ask
this side.
Yes. Who
Yeah,
is?
go ahead, please. Probably I'll just
I,
mute myself.
I just wanted to ask Elizabeth, can we use your ESCORT checklist right away in our setting?
You can. It is just validated within our setup only. If you want, you can validate also. No problem. It's been developed by us only.
I was going to
Thank
ask
you.
that. So not only Margaret, I think if a couple of more hospitals we can try that out and make that into a evidence-based practice, right?
Yes.
So I think some of you have already done. So Karishma is asking. So I always think that when you are anyway putting effort, put a little bit more effort and make it that whether we can publish this,
Yes, yes.
right?
It's
Follow the
all the process, ma'am.
evidence-based practice, follow the evidence-based practice standards, and you will have a multi-center, a study that you can do. So will you be able to do that, Elizabeth?
Yes, ma'am.
So
Definitely.
you are going to be the driver for that. So don't give them the checklist and forget it.
Okay.
So we have Margaret and we have also Karishma who volunteered. Anybody else? This is actually very nice because when you have something you see, you actually come out with action. That is our tagline, passion to action. Very good. Dr. Jyoti Chowdhury, she's from West Bengal. So she
Ma'am, Abdul this side. I'm sorry for
Abdul,
the background noise because I'm just getting back from the office. So much
very
of horns and honking. Yeah, okay. Ma'am, I would like to add to your code because I just was also wanting to know what the precautionary type was. And thanks for
Abdul,
explaining
one
that.
second. Your voice is slightly, getting muffled. Maybe keep the mic a little far. Sridevi
Yeah,
Shantaraju.
oh,
So
okay, sure, sure.
saying, don't forget, in the Annie members, you will find Professor Elizabeth Berkey. So please send her a message and then you make a team, Elizabeth, yeah?
Sure,
So
sure.
a multi-center, study, it will be good. It will be really nice. Go ahead, Abdul.
Yeah. On this outset, I would like to thank Ms. Elizabeth because this moot court we had to introduce at HCC when she was our NEB assessor for our flagship hospital last year. So she was discussing about moot court, and I had to copy that same idea, and probably not in that particular level of structured way what probably they are doing it, but for the copied idea, what I've got, and we have started adopting this. Really, it is really acting as a modality to make nurses understand the impact of incidences what they are creating. So now what we're trying to do is every monthly based on our analysis of the indicators, those events are being converted into form of a mood, and we have done a quality learning day. So that particular day, this particular mood court scenarios have been enacted. And thanks for that particular idea what you gave us long time back, and then
Thank you.
probably we have adopted that. And I will also be implemented. I will connect with you probably.
Sure, sure, sure. Thank you.
There is a question from Vinci, ma'am. Is the ESCORT checklist created by the project team or is it adopted from some guideline?
Yes, ma'am. It's a modified one. Actually, there was checklist for this, but we had modified it based upon our.
Okay, so I think the rest of the questions more into escorts. So please, we are anyway.
Professor Elizabeth,
Yes, ma'am.
Go ahead. I'll stop.
ma'am, can I ask one question, please?
Sure, ma'am.
Yeah, Professor Elizabeth, thank you so much. And it was a very nice presentation. I really appreciate.
Thank you.
Yeah. And this moot court idea, which is very excellent. And then we under forensic
We have
nursing.
lost you, Pradipa
For
Chandekar.
nursing
Sorry, we are not able to hear you.
Since we have a medical
So
college
not
in
able
the
to hear you. So
same
all of you who would like to
campus,
join us the moot court,
so
we will invite you
we are
all to Kochi
using our
on the
students.
30th and 31st. So
We
during
got-
Anicon, and after that, there are some ideas coming into my head.
okay.
what to do with the moot court. So we will do
just
that after
wanted,
the moot court is done during Anicon, right?
yeah,
So
no,
how moot courts
I
before
just
that? All
wanted
right. So let's keep it as a surprise for everyone.
for
Okay, so we will do that.
precautionary.
So and yes, Elizabeth, I would definitely request that this is good thing that people are wanting to use the checklist. So do a proper research route or evidence based route, but both of them, research is not an issue. I would definitely like to follow the EBP way, so that at least it's an evidence that is made available in India, and then paper will be very India oriented thing.
Yes.
So go ahead, and we have great people who are wanting to this thing, and some of them are asking whether they can get the video of the precautionary tail and moot court link. So that is from Vinci Sunil. So I think you all need to get in touch with Dr. Professor Elizabeth Workey directly. So can we give some examples for precautionary tails?
Yes,
So
ma'am.
maybe what you explained, it came up very fast. So maybe you tell one story so that they understand.
Okay. For example, if it's like a collection of samples, so that will be the process. So how we do normally, something have come up like we'll be taking a vacutainer, we'll be checking it, something like that. Okay, we'll see, oh, whether this is a patient. It's something which I said it's not like the normal procedures that we have to do. So what has been done here, or might be handing over. Sometimes a handing over, like how we do a handing over. You'll see that, oh, whether somebody's looking, oh, nothing is there. You put a check, tick, 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 so many ticks are there. Otherwise, the supervisor will be coming. We'll see that. So all these kinds of funny things will be explained. Second is like how it has to be done. For example, we have a systematic method of I pass the baton or ISBA. So how this has to be done. So even that we in our institution, we had the scripted communication where the staff has to explain myself. I'm Elizabeth Workey. So today I'll be in the morning shift from 7 to 2. So then, so I'll be taking care of you. And if you have any problems, you can come to me like that and all we'll be describing. So this has been explained in the second session, how it has to go over. And the ISBA, like I pass the baton or the ISBA form the format, they'll be showing how we have to explain about introduction, how to introduce ourselves, a situation, what are things we have to cover up. So all these by means systematically described or it has been enacted in the second session. So this is what is happening there.
If I can add to what Elizabeth just explained, is actually you take a problematic area, a
Yeah.
process where you are finding nurses are doing shortcuts to it. Is also a simulation principle only. We are just giving them different names, and it's very interesting for them because they are the ones who are writing the script. This is we used to call them role plays before.
Yeah.
Like I have done a role play in 2001 where the patient is anesthetized with socks. The
Okay.
socks is so smelly that
Okay.
does that and patient becomes
Okay.
unconscious. But the story was there that the patient wrong surgery.
Okay.
The patient tells, I have chest pain.
Okay.
And being cardiac center, everybody assumed it is cardiac pain. The patient actually had ulcer, gastric ulcer.
Okay.
So that, patient end up having CABG surgery. In real life, he won't have CABG surgery. But in the drama, we show patient is having CABG surgery. So that became very powerful because we have multidisciplinary, even doctors, they will come. Doctors, if you are doing drama, they will come. You are saying that we have a learning session, they will not come. So that is the benefit of having all this. If you call them and say, okay, you be the judge, then we'll say, okay, today's drama is this. Then they'll ask, what drama, Tankam? I said, come and see the drama. And the drama will involve a doctor also.
Yes,
Then
yes.
there will be some discussion that happens. So that way we were able to engage. So when I actually learned about simulation, I realized that my entire life I had been using that principle because I always believed you have to engage with the learners to sensitize. Lectures are required in some, topics, and it is required. It can keep you, restricted to the thing that you want to talk. Otherwise, you'll be talking all over the place. So this concept of role play, I think forever we have known. It is just that when the simulation has come, the different stages of simulation you keep in mind so that the objectives are finally achieved. So even when we were doing drama, we had the objectives. So in this
Yes.
drama, the objective, the socks part was not the objective. That was only for fun.
Yeah.
We also used to do, you know, singing drama, you know, like in Hindi, the nurse will go and ask, na, आज क्या है जनाब आज आपका हाल क्या है जनाब का पेशेंट से क्या ख्याल है आपका जसमिन दिल तो मचल गए हा हा ha. Oh, so we used to do all this, and for all these sessions, doctors will be there because they say something is happening today. Otherwise, it was very difficult to get them. And we also did a fashion show for Infection Prevention Week.
That's
So then everybody was like, "What fashion show?" I said, "You come. I am not going to explain this to you." Then that was a very interesting, you know, way all my nurses are involved in all that. It was definitely a fashion show. We had very talented educator with me. He was a male nurse. So we sat down and we designed all the dresses. The dresses were all made from biomedical waste.
oh, nice. Very nice.
So all the doctors came to see the fashion show. Before that, we presented our findings and everything. They said, "Where is the fashion show?" I said, "Wait, wait. First, we will tell you what we have to tell you, you know." So they listened, and then we have the ramp walk just with the fashions song,
Yeah.
the movie fashion.
Mm.
We had that song playing, and
Okay.
even the designer walked with the showstopper,
Wow.
who was wearing the blue waist bag sari.
Ah, nice.
And she had IV caps, as you know, everything was made of biomedical waste related thing. So there was a lot of excitement, lot of work, but then everybody was excited. So there was a lot of engagement. So you know, telling this street play, yes, all these things we had been doing. So it is just that your creativity is your limitation. So it's very nice to see. But for all this, you know, always remember the principle is the simulation, you know, where so the pre-briefing, you will definitely plan, no? Moot court will not happen. You cannot just get up and do a moot court. So you'll do a pre-briefing. You will brief the people also. This is what is when people who are in the moot court. And definitely the moot court will happen. That is the simulation. And in the end, you have some form of debriefing, isn't it? What happened here? Why did it happen? Why did the judge decide like
Yeah.
that? You know? What could have gone wrong? So your objective is limited to that particular case. You will not go outside that case, right?
Yes.
And the right questions the vakil will ask, no?
Yes. Yes.
That is your debriefing already.
Yeah.
I'm very excited. I wish I could do, if I was in a hospital, I would have done a moot court.
Ma'am,
Multiple.
join us, Nanny. We'll together do that.
No, I will be the observing judge. Okay, I think that's really interesting. You know, very good. So great. Any other comments or um, questions? Otherwise, we are good to say bye-bye. I think we had a lot of light-hearted moments also in this session. So it's important to remember nursing is a very serious profession. That does not mean that we have to be serious all the time, right?
Yes, ma'am.
Have to be serious with our young nurses also. No, they are human beings. They would like to be around pleasant people.
Yes, yes.
If they are working with people who, you know, who are sick and suffering, they have to modulate their emotions all the time. But when they come to us to learn, when they come to us to discuss, we can be pleasant, right?
Definitely.
And be there for them. That's very important, you know.
Yes, yes.
Great. So that's great. So thanks, Elizabeth, for generating all these different discussions, and we will definitely have work to do.
Yes,
That's
always.
very nice. I am very, very happy when a webinar ends in another action. That means we are progressive. Otherwise, we are only talking, right?
Yes.
So great. So all of you who said yes, please, I know your names. I will definitely come after you. Okay. Thank you so much. And I don't know if Ajita, are you still there? Would you like to
Yes,
say a few
ma'am.
words?
Yes, ma'am. I am here. I am
Nice to
here.
see you once in a while. You're still in office. Chalo.
I'm
Ma'am.
in office. I have some more work to do, so I thought I'll sit here and finish, and then it was this. So thank you, Elizabeth. It was a very engaging and very nice session, and some novel ideas for some people, which are doable. What I'm happy about it is doable ideas, and we definitely have to, think out of the box as to how do we, instill certain things, certain values, certain principles, certain, procedures to our younger people, right? And not only younger, everybody, I feel at times. And it is the age-old lecturing and shouting at people and making them writing written explanations and all are not going to work anymore. We've seen that people don't care about it, and it is just not working. So maybe these kind of innovative things, many more of it, will help not only the administrators but also of the nursing staff. And I won't limit it to that, but maybe doctors and maybe other people who are involved in healthcare too, to understand the perspective of how do we work at the bedside, and what are the intricacies of it, what are the various dimensions of it. It's a very complex process, whatever we may say. These kind of things, you are watching a situation which you know that there is no practical threat out there and you're acting it out, but at the same time you can identify with the people around there with your past experience, and learning would be much better. Correct? So that
Yes.
these are the advantages of having these kind of things. And maybe the situation based, these kind of learning things are probably, it will open up their brains and it will tickle their reasoning center in brain, because that doesn't really work nowadays, and that is the problem what we have. People end up doing stupid blunders without any reasoning or without the application of mind, and we come across this every day in our life, right? So sometimes we wonder, how do people end up doing such stupid things, which obviously is wrong, but then their rationale at that particular point did not work. And safety is as much as our younger ones do it at the bedside, right? How much ever we all speak in boardrooms doesn't really translate to safety unless and until everybody in the system is tuned to how do we look for reasoning, and without rationalization we don't do anything just because someone said or you felt like doing that and things like that. So these kind of learning methods are really promising, I would say, and long way to go, however, as Madam Tangam said. But it's really giving us hope at the same time, how, I mean, the response of the people sitting there you have seen, and it is 754, but still we have 93 people, and very happy about the response of the people, because everyone is on the other side, right? I mean, it's not only we are struggling, everyone is struggling out there, both the staff nurses as well as the administrators and supervisors. Everyone is finding it very tough to, each day is really a task, isn't it? Time changed, and it's very difficult, actually speaking, to lead nursing department in the current time than it used to be, say, 5 years ago. I guess 5 years ago it was a little more better. 10 years ago it was much more better. But as time goes, it's becoming more and more challenging because of uh, the situational pressure, the way people look at things, and how they are getting influenced by various factors which are out there in the society, including social media, including, if you say the example of Kerala, drug abuse is coming in a big way. So I feel that our staff are also living in the society, and we have to be understanding these things. So you have to find better ways of telling them how do we, certain things which are very important at the bedside when they work, and thank you so much for bringing light into these kind of methods, and I'm sure there will be a lot of takers. So a lot many people were asking for videos from you, but a word of caution to you, screen out those patient details, because you have to keep confidentiality, and I'm sure you'll be telling patient's name or something. If it is an acted out scene, it's okay, but otherwise.
Exactly.
Thank you so
There is
much.
one question, Elizabeth. I think we
Yes,
need to
ma'am.
answer that. Ma'am, did you encounter any guilt feel on the staffs when they participated or enacted on the moot court or tail scenarios? I think tail scenarios probably may not, because it's very generic, but when you discuss a particular case in the moot court, there is a possibility. It's a very good question from Jaba Pakyam from Apollo Main Hospital, Chennai. Would you like to take that?
Yes, ma'am. Definitely, there were certain incidents in which some incidents was taken up as in the moot court. That was a kind of sensitive issue actually, but it was all things as ma'am mentioned. It was all maintained. The confidentiality and privacy, all thing was maintained. But the staff knew who was that real victim. So actually, she came to me at the end of that moot court and asked me, "Ma'am, can I just address the gathering?" So she took up the stage and she told that this victim was myself. The second victim was myself. But she was explaining what had happened, and she was narrating the various steps in which she failed to do. And she also had to undergo certain kinds of legal aspects also with some police encounter and all. So she was just literally crying and saying and asking our nurses that please don't do this, what mistake which I have done. So she was emphasizing that these kinds of checklists, these kinds of checks are so important, especially when dealing with patients. So she was telling that it's my plea to everybody to please follow these things, whatever it has been shown here, please follow that. So she has come up with such a kind, and she was in tears also. So
Fantastic, fantastic. I think that nurse must be rewarded, recognized,
yes,
awarded, because it takes a lot of courage
yeah,
to come up and say, that's me. And, nobody can be a better teacher than her.
yes, ma'am.
Nobody can be. Please, from my side, you must say thank
She,
you
she, she
for
has left us, but when she has gone, I have given a very good certificate for her.
very
And
good. Wherever she is, if you
yeah,
please
yeah,
tell her that, that takes a lot of courage for
yes,
someone to do that. And
yes,
that can be hugely influential for the young nurses.
yes,
That's very
yes,
important. You can tell, I can tell, they will all look at it with a pinch of salt and say they are very patronizing.
yeah,
But
yeah,
someone says, this is what happened to me, this is what I learned, that makes a huge
yes,
difference.
yes, ma'am.
That's a great discussion, because in the Empower Hour also, the discussion was about second victim today. So there were young nurses sharing their, experience,
Emotions.
good thing. I'm very happy that Annie is able to facilitate these kind of discussions, which were not heard of, at least before we came into the picture. And we are very thankful to all the members who are joining us and all the leaders who are supporting, and obviously all the people who come to all these sessions, every month. There is Empower Hour, there is Safe Sessions, whatever is the number of sessions, we keep getting good numbers. So thank you so much, everyone, and take care. And thanks, Ajita, for your words. They're very powerful and they're very relevant, of course. So let's go back and commit ourselves again to continue to do great job. There will be ups and downs, and let's learn and make it, more engaging for our young nurses to learn the important aspects of, giving safe care to our patients. Thank you so much.
Thank you, ma'am.
And
Thank you
we
so
will
much.
see you next month, discussing about restraints. Okay.
Yes, ma'am.
Bye bye.
Bye bye.
Thank you, ma'am.
Thank you, ma'am.
Okay.
Thank you so
Bye.
much.
Bye bye.